All right, so good afternoon. My name is Erin Wolfson. I am the Community Engagement Specialist with the Division of Social Accountability with the College of Medicine. Before we begin, I would like to acknowledge that we are on Treaty 6 territory and the homeland of the Métis. We pay our respects to the First Nation and Métis ancestors of this place, and we reaffirm our relationship with one another. So welcome to the launch of Conversations for Health Equity, an event hosted by the Division of Social Accountability and the College of Medicine. We are so happy you're here with us today. We hope this new lecture series will be a space where we can discuss new opportunities and approaches to achieve health equity in the communities that we serve. Our Learning Lab will feature health equity champions and advocates. Their stories and innovative strategies will open up the door for dialogue and collaborative action. Further topics will explore pathways to Indigenous health equity, meaningful and authentic community engagement, advocacy and taking action on the social determinants of health, as well as innovations in social accountability and medical and health professional education, including ways that health professional schools are contributing to the development of more equitable health systems and healthier communities. We hope this will be a space for critical conversation, recognizing that together we can move towards achieving greater health equity in our communities. Before you leave today, please do take a few minutes to fill out the feedback form that you've been given. This really will help us plan for future events and conversations. And please suggest future topics of speakers that you would like to hear. I also want to let you know that we will be recording this talk today so that conversations can continue. And if you have any concerns about this, please don't hesitate to come speak with me afterwards. Finally, I would really like to express our gratitude to the College of Medicine, the Dean's Office, for sponsoring lunch. I hope you enjoy it, and please do continue to grab some lunch as we have this conversation today. All right, well, we're very happy to have Erin Beckwell here today to lead us in our very first conversation. Erin joins us from the Public Health Observatory in the Saskatchewan Health Authority, where she works as a knowledge translation specialist and a policy analyst. She is passionate about transforming the health system to achieve health equity and providing culturally safe care for all. Please, let's give her a warm welcome.
Thank you, Erin. Can everybody hear me? Regina, we're good? Yeah? Okay, I'll take that as a yes. So Erin already acknowledged that we're on Treaty 6 territory here in Saskatoon. I also want to acknowledge Saskatchewan Health Authority covers not just Treaty 6, but 2, 4, 5, 6, 8, and 10, as well as homeland of the Métis. I'm going to start us off by running through fairly quickly, because we don't have a lot of time together today, some information about health equity and cultural safety. What are we talking about? What does this even mean? And then hopefully we'll move pretty quickly into, as Erin mentioned, some of those critical conversations about, so what? What do we do with all of this? I mean, these are lovely aspirational ideas. What does it actually look like in real practice? So just for a bit of context, I currently work in the Public Health Observatory downtown Saskatoon. My title is Knowledge Translation Specialist. Some of you, I find in academic settings, more people actually have some vague sense of what that might mean. Often in community, people give me like a blank, what does that even mean? And I'm like, good question. I'm not sure myself most days. But one of the things that I focus most of my time on is health equity and cultural safety, and how do we transform our health system to be more accessible, affordable, appropriate for all people. So this conversation is going to sort of be the quick and dirty version of what often comes across in much more in-depth, ongoing, longer conversations. So hopefully you can bear with us, particularly if this is not new to you and you're sort of like eagerly waiting for the so what part. I will try to do this justice and cover it as quickly as we can. So just sort of as a starting point, health inequities are differences between population groups, so those could be social, economic, demographic, geographic, that are unfair, avoidable, and systematic. So that's just sort of the base assumption we're working from, is that inequities in health exist. There's tons of research that substantiates that, including some from Saskatoon, Regina, Saskatchewan, and of course across Canada. So here's one example of an inequity, life expectancy at birth. And so this is 2012 data. So the gap between the least advantaged people in urban Saskatoon and the most advantaged is about 8 years. That's actually marginally better than it was a few years back. So we're making little tiny incremental steps. I would love to be able to claim sole responsibility for that, but I know that is a massive Herculean effort that crosses sectors and actually is probably not much to do with the healthcare system itself. So here's another way we often talk about this, that when it comes to health, your postal code matters more than your genetic code. Where you live, the neighborhood you live, work, and play in actually has far greater influence on your health than your genetics when you come into the world, but also even the health systems you access. So that sort of social and physical environment is a huge factor in health, and one that our health system actually isn't structured well to acknowledge and address. So we are often working so far downstream that it is even challenging to get people to acknowledge that this is indeed true. Partly, I think, because that it seems so overwhelming to acknowledge that is indeed a very big part of the challenge people are facing in attaining their best health, that what do we do about that, particularly when the solutions to some of this or the interventions we could propose or actually implement fall far beyond the reaches of health, gives us an easy out. Well, we can't fix that, so we just carry on doing what we do. So one of the reasons my position exists is to help facilitate those conversations in the health system, but also bridging out to community partners and places like the health providers being educated, so that we're shifting the conversation gradually. So health equity is the principle and commitment to incorporating fairness in health by specifically identifying and reducing health inequities. So it implies that everyone can reach their full health potential and shouldn't be disadvantaged from a range of social, geographic, demographic characteristics. So all kinds of socially determined circumstances, there's a list there. And so one of the most popular ways we talk about this idea, and many of you have probably seen this image, it was developed in our office, is the equality doesn't mean equity infographic. So we used to issue very large reports about health equity, and a few years back stopped doing that and shifted to one-page summaries and visuals. And it's been fascinating how the engagement has shifted and the diversity of audiences that have engaged in this conversation since we've shifted away from more technical reports to something that is certainly more accessible to more people and seen as perhaps more relevant to folks in their practice or in their daily lives. So this image has actually been shown around the world, including at the WHO, partly because people sometimes struggle to wrap their head around why it's maybe not the best strategy to treat everyone the same. Because certainly we often live in a world that promotes this notion of equality as the ideal. And the reality is we do not live in a world that is the ideal. And so therefore we have many, many social circumstances that are impacting people's ability to, in this case, get the apple off the tree or achieve best health, access healthcare, and so on. So we need to adjust the supports we give folks to actually help everyone attain their health goals or live their best health. So one of the things we've started talking about a lot in concert with this, our conversations about health equity is culture. And some of that has come, of course, as a result of the Truth and Reconciliation Commission's calls to action. The Saskatoon Health Region, prior to the advent of the Health Authority, had signed a declaration of commitment to respond to the calls to action. So has St. Paul's Hospital and various other health centers, groups, and organizations throughout our province. The University of Saskatchewan has done the same. And so what does that actually mean on the ground, in our work? How can we go beyond really nice words and actually have some really tough conversations and talk about what is it going to take to change our practice? What is it going to take to change our system and the context in which we practice to hopefully shift us to cultural safety. So even very recently, more and more people are understanding or have heard of cultural safety. How many folks in here and in Regina have heard of cultural safety? So quite a few. Could be a little bit of biased group here because you self-selected to come. But one of the interesting things is a lot of times I get questions like, what about competency? I thought competency was the thing. And now you're telling me it's safety. I don't even know what that is. And lots of folks who've been practicing for quite a long period of time are like, that term wasn't around when I was trained. I don't hear it in my workspaces. It's not included in any of our accountabilities or our reporting. So I'm really unfamiliar with the term. And what's wrong with competency? Is it bad now? So hopefully this will give you a bit of a sense of sort of where things fit together. There are different interpretations and sort of translations of different models and paradigms of talking about culture in health. So I will just preface this with this is the paradigm we use in our health authority today. It could change tomorrow. But competency tends to focus on behavior, attitude, and policy. It tends to put the onus and the power in the hands of the health provider or the health decision maker. And in that sense, I mean a healthcare leader or a person of influence in a health system. So competency isn't inherently bad. But it has gaps and it doesn't quite get there in that you can be or feel you are, believe you are, incredibly competent culturally as a health provider, yet the person that you are supporting or providing care to may not experience your care as culturally safe. So they may not feel your cultural competency has a positive impact on their experience with you because competency also tends to focus on the attainment of knowledge about others. So it tends to separate us into us and them and say we need to learn about other cultures. It does not necessarily require us to identify and explore our own culture and how that impacts how we provide services, how we engage with people in our work and in our personal lives. And it doesn't talk about things like implicit bias or, cultural bias. So we're going to get into that in a moment. So it leaves the power of the interaction in the hands of the professional. So it doesn't actually go about intentionally redistributing power. There are certainly some practitioners who've been trained in a competency model who do practice in those ways where they are very intentionally naming differences in power, sharing power, doing self-reflection on their own cultural identity and how that influences their approach to care. But cultural competence in and of itself doesn't usually prepare people to do that well. And one of the other things is, and this quote from Brascoupé and Waters talks about how cultural competency actually isn't a precursor to cultural safety in a lot of situations. So cultural safety is about something different. And so folks are often struggling, okay, then what do I do? Tell me what to do to make my care culturally safe. So one of the alternative ways of understanding and approaching culture in our practice is to think about humility rather than competency, or humility and competency together. So it's not about attaining or achieving a particular degree of awareness, knowledge, competency, but about self-humility and self-reflection. So it's a lifelong process rather than an outcome and that sort of point of, I can now feel culturally competent because I learned about what are the top 10 things to be mindful of when working with an Indigenous patient or client. And not often in my work in the health system, one of the most common requests I get is, can you give me a checklist for how to work better with insert cultural group here or population, which I understand the yearning for that concreteness and that sense of certainty that there are specific things I can do. So much of what people have told us about their experiences accessing a system is it's not about what we do, it's about how we do it. Really what people are yearning for is someone who connects with them as a fellow human being and that approaches their work from a place of prioritizing respect, dignity, which all of us have an ethical obligation to do, but often because of the way our work is structured, because of the way our systems are structured, we end up not necessarily communicating that well in that patients feel it. Some of it is also, we don't acknowledge history. And so if we don't acknowledge people's history, maybe not with us personally, but with the system that we are employed by or that we strive to work in, we actually do not create conditions where people feel safe. People may feel, you don't understand how it is coming in here for me. So we may feel we are being very open and very accessible and very supportive, yet if we aren't actually able to understand and acknowledge that it can take a great amount of energy, a great amount of perhaps bravery, perhaps just desperation to actually set foot in some of our healthcare settings. And if we are unable to actually have some understanding of that and acknowledge that to the people we're supporting, we may continue to feel like we're falling short, even if we know some of the right things we're supposed to be doing. The other thing that's sort of a difference between humility and competency often has been critiqued because it tends to focus on some pretty broad generalizations about cultural groups and doesn't acknowledge that culture is a very individual experience that happens in a community collective context. But that when we think about, when I was first taught about working with, at the time, the language would have been Indigenous or Aboriginal people, when we were taught that, it was, don't make eye contact, don't use a firm hand grip, because that's seen as, not appropriate. And there were these sort of very sort of superficial and very, very broad generalizations about, without any context of why, but it was that's what Aboriginal people want. That's what's appropriate for work with Aboriginal people, which perhaps with some, that is appropriate, but certainly not with, I would say, most people that I've encountered in my practice and my professional life. So it can send us down a path where we think we know. And cultural humility requires us to be willing to suspend what we know or what we think we know, to be open to this person's own experience, identification, manifestation of what their culture is. So it means we have to allow that personal expression of heritage and culture without us imposing what we think it means to be whatever their cultural identity is. Even assuming we know cultural identity based on appearance, based on previous interactions with other folks, that we then know what it means for this person, can be quite the pitfall we can get into. So cultural safety is an outcome. So it is safety, cultural safety is defined by the people who access services. So clients, patients, residents, families, and so on. So it is based on things that many of us are probably not surprised to see, because we likely have heard and talked about some of this before. Things like respect and dignity, which are pretty foundational in codes of ethics for healthcare workers and other professions as well. But it also is linked in with trauma-informed interaction. If you don't know much, I don't have time to go into trauma-informed practice much today, but if you're curious about that, Google it and you will find all kinds of stuff. Or my email address is at the end, and you're welcome to connect with me later, and I can send you some resources and have a conversation about that. But the notion that we understand that people may have a history of trauma, that trauma may be unresolved, it may impact how they interact in our care, but also in our system. We also need to understand power dynamics inherent in health service delivery, and actually believe that those have an impact on how people navigate our services and interact with us. We need to name and understand institutional discrimination, and go beyond our individual practice and be part of system-level change, which is incredibly challenging. One of the things that's fascinating, though, is that I truly believe that a lot of folks understand and see how the system should change or could change, but feel in their own way quite helpless, powerless, or just overwhelmed with what to do about that. So collectively, if we all sit there we're unlikely to see a lot of change in the near future. So it's a matter of how do we create a critical mass of what can I change today, and then how can I be part of a bigger conversation and process of change. So this First Nation Health Authority in British Columbia is doing amazing work around cultural safety, humility, and various other initiatives around Indigenous health. I encourage you to check them out. So I use a lot of their resources in the work I do, and it talks about often, in order to provide culturally safe care, we need to be humble enough to admit that we don't know everything about everyone's life experiences, which most of us are probably like, yeah, I would never claim that. Sometimes I think we feel pressured to appear that we do understand a lot more than we do. And that's part of our professional culture and our system culture, is that health providers are supposed to know stuff. So if we start acknowledging we don't know all the things, that's a pretty vulnerable place to be in. It's pretty uncomfortable, and there may be spaces and roles where that is actually not well supported by our system. That may actually be challenged and critiqued by our colleagues, by our supervisors, by our leaders. And so how do we create spaces in the health system where it's okay to say, I don't know? How liberating would that be, by the way? A lot of people are like, oh, I want to crawl under the table right now because that sounds awful. For me, it was one of the most liberating things I learned in my professional practice was I don't have to know. And I can actually, it's actually one of the best relationship building tools I have is to be humble enough and make myself vulnerable by sharing with someone, I actually don't know the answer to that, or I've never encountered this before. Can you help me understand what that is like? And it has been one of the most transformative pieces of my work, even now that I'm not doing frontline work, to be able to go into a space where people position me or they position themselves as an expert and be like, it's okay to not know that. And people will be like, oh, all right, rather than I'm going to pretend I know more than I do. And so we sometimes think about those things and perhaps in the cost to ourselves, the cost in terms of potential for error and so on. But we often don't think about how that would feel because people do pick up on that. Particularly people who have a background of trauma and oppression, they're often primed to be hypervigilant and pick up on people who are saying things and not knowing and not seeing them. So it tends to create this gap where people can't trust, where people maybe question or don't share as much as they might because the person who's trying to provide a service to them is trying to look like they know all the things when it's impossible for any of us to know everything. So we need to create a culture where that's all right. So the other thing cultural safety does is it talks about the reality that we all have culture. And this is another piece we don't have a lot of time to unpack here, but I think it's really, really essential, is for many of us, particularly those of us who are settler-identified folks, we may not have a strong sense of culture or feel that our culture is Canadian, whatever that means, right? And so it tends to negate the reality that our cultural values and practices are actually manifesting in how we provide service all the time. So a quick example, I have grown up with a whole wealth of health challenges. I have been in and out of the system, the health system, my entire life, since I was born. I grew up in a family where the priority was always, well, Erin needs to drive 3.5 hours to go to RUH to see a specialist. That just happened. And I didn't understand that that wasn't how that happened for everyone. I also endured painful procedures and a lot of like, we don't know what's wrong with you, or what is wrong with you, questions with family who said, I know this kind of is awful, but they're going to help you get better, trust them, messages over and over and over again. And so when I go into a space now as an adult, I also had a mom often who came with me and questioned nurses and doctors and other health providers and asked the questions she needed because she's feisty and that's how she rolls. And so now I have a sense of agency. When I go into a specialist's office, I'm like, okay, here's my list of questions and I've done my research and I'm gonna... And I didn't understand until fairly recently the amount of privilege that is packed into my capacity to navigate the health system the way I do and get what I need. And I still don't always get what I need from the system. So what happens for folks who've experienced abuse, racism, who've had the experience where hospitals are where my family, community, and entire world goes and they die and they don't come back out again, and that's the reality. So for me to walk in to a hospital, that was never part of even my awareness. I knew people died in hospital, but it wasn't a sense that that's what everyone I know, that's their stories. They go to the hospital and they don't come back. So why would I voluntarily go? How am I going to feel if I choose to go? And what will that experience like? So we need to also acknowledge culture isn't just about ethnocultural experience. Culture is bigger than that, and it influences how we relate to our own health, the provision of health, and the healthcare system. So we need to go beyond competency, bigger than competency, and think about power imbalances, discrimination, colonization, colonial relationships as they apply to health and healthcare. So a lot of people say, okay, if this is an outcome, how do we know if we get there? When we have First Nations people, perhaps newcomers, other cultural groups that have historically experienced and currently are still experiencing oppression through the system or in society in general, start saying the care is culturally safe. So that could be an individual saying, yes, that was okay. It could be a community saying this service, we're experiencing this as culturally safe. Eventually the goal is we have a system that people's relationship with it is experienced as culturally safe. But we don't get to define that. We don't get to say that. And that is really, really challenging because so often the work that I'm doing is involved in talking with folks about how do we measure, and we're going to talk about this in a minute, the outcome or the impact or the effectiveness of our healthcare. And very rarely, and often only in selective ways, are we actually asking people who access healthcare how effective, what the impact. So we have to figure out how to ask. And one of the challenges around cultural safety is we can't necessarily just ask people as they're leaving our hospital or at the end of an appointment, because if people do not feel culturally safe, they'll either say, yeah, it was fine, or they won't answer, or we won't get the information we need. So we have to get creative and think a little bit differently about how we start trying to measure cultural safety and how we engage with folks to try to get some of that information. So one of the ways that we've talked about this in the health system and gotten a little bit of traction, which at first, I mean, my background professionally is social work. So I'm more about the relationship, less about, quantifying an outcome of some, having an indicator for, it's like, yeah, my work doesn't really fit that model well often. And so it was a struggle to sort of fit into mainstream and sort of health system conversations about quality. And I had to work pretty hard at first, and I know some of my colleagues did as well. Others found it less onerous. But one of the things we found is so much of the literature about quality in health systems actually talks about health equity. But when we were talking about in our system, and this is not just our system, it was lots of systems, it's nowhere to be found. Like, people just kind of dropped that off. Like, it's not there. So the Institute of Medicine, for example, 17 years ago, released a report that talked about 6 dimensions of quality healthcare, and equitable care was one of the main ones. We certainly spend a lot of time talking about effectiveness and efficiency, safety, absolutely, timeliness, so we talk about wait lists and wait times, and patient-centered and person-centered care is getting more attention gradually, but that piece around equity has been sort of the elusive, like, we'll just hide that black sheep over in the corner and lock it up and pretend that's not part of this conversation. A lot of the research actually says if we do not consider equity, we will never fully realize our goals around quality. And so it is a pretty significant misstep to actually just focus on select domains of this. The other thing that we have found, of course, is that equity doesn't just sort of live out on its own as this thing that's completely removed from the rest of how we understand quality in healthcare. It is actually intersecting all of these things. They are all interrelated. So when we talk about, for example, patient family-centered care, client family-centered care, one of the questions that I was asking at some of those meetings is, how do we go about engaging with clients and families? Because there's a whole process in our system for how do we capture the voice and experience of people who have been patients, who've accessed our care. And so I asked the question, I said, so how do we recruit people who become patient advisors? Well, health providers typically identify people they think would have something to offer. Okay, so who's going to be identified through that process, do you guys think? Good patients, yes, people who are good patients, perhaps people who are articulate, engaged, who are perceived as having time and energy and space to actually contribute in a role like a patient advisor. Typically, what we find, though, a lot of former health providers become patient advisors, which is fascinating to me. But the question I always ask is, okay, those folks have a very important perspective to share with it, absolutely. But whose perspective are we never probably hearing through that process? Who is missing from that process? And part of that is structural because of how those systems work. So you have to apply, go through a screening process. You have to have access to the internet consistently because they post opportunities for advisors online. All the communication comes through email. There are particular requirements around signing up to receive honoraria for those roles. And all of those things are okay for some people. But they are barriers upon barriers upon barriers for others. The other thing I asked was the meetings for our patient family advisory councils very consistently, we have over 20 of them in Saskatoon alone, happen in hospitals. And so I just said, do you guys ever meet elsewhere? What do you mean? It's like, well, there are other places other than hospitals. Yeah, but like that's where all our staff are. Correct? Is this a staff advisory council? Like I maybe missed something. And the reality is we structure these things for the convenience of our staff. And there were assumptions made about what other reasons why that worked. And some of those I think are pretty legit. Like we like to go into a unit and actually see how things are happening in real time. And you can't do that if you're not there. Yeah, that's a really good reason. What about people whose experience in the hospital was traumatic, was just plain awful, and coming back in this building is actually not okay? We will probably not see them on patient family advisory councils because they will have to come into our space and be on our turf, essentially. The other interesting thing is I was at one of the patient family advisory councils and they were meeting in the executive boardroom at RUH, which is a lovely oak-paneled room with big cushy chairs and a massive table. And I said, so is there a reason why this is the room? And they're like, some of our advisors get a kick of sitting in the chair that, some of our senior leaders sit in. And I was like, are you sure about that? Some maybe do. But there are some that probably wouldn't be an incentive to become a patient family advisor and have a meeting on the 6th floor of the old wing of RUH in a big wood-paneled boardroom. That may be a place they don't feel they belong, that they don't feel they can contribute, and even some of the things we ask from folks around commitment. So people are asked to commit a year. Some people, that is never going to be a commitment they can make. Can they contribute their perspective in other ways that meet their needs and where they're at? So a few other things around quality. This is a question that I have been encouraging folks to ask as often as you can, in as many situations as you can. We often are asking, how well does it work? How effective is it, in essence? We also need to ask for whom. So is this working well for everyone? One of the pitfalls of our paradigm around quality improvement has been, we look at the 80%. We look at the middle group of people, and we often are instructed to not worry about the outliers who fall on the ends of that. The reality is the people who are struggling to access care and are probably experiencing the poorest outcomes in health are on one end of that spectrum, for sure. And so if we are actually just, well, let's not consider those folks, because we're thinking about the big group in the middle. That's who we need to move the dial for. So we may actually inadvertently, in our quality improvement activities, be widening gaps in health without even knowing, because we're not measuring what's happening for people on the outliers, right? The people on both ends of the spectrum. So we need to constantly remind ourselves to ask, is this working for everyone? And it may be, we don't know. Then what do we need to do to find out? Is it we don't collect the right information? We don't ask the right questions? We don't have the right people at the table? And so how can we actually start asking some critical questions? The other thing that's important to understand is we may attempt to engage people in, say, quality improvement or other types of work that's more collaborative, but people may not just sort of step up to the table and tell all right away. They may not trust us with their story, with their experience, to do something. They may have tried to tell people before and had nothing happen. They may have tried to tell people before and been told it was their fault, or they just need to change their attitude and be more positive about things, all kinds of things. And these are all examples based on stories from patients who've accessed our system. So the notion that we need to build trust in order to truly engage with folks in our system, and that includes the people who work in the system. So a lot of health providers also feel they can't trust the system they work in sometimes, or that their voice isn't valued and heard. So therefore, when it comes time to offer feedback or engage in a process of quality improvement, they may be doing so in a minimal way, just enough to kind of get the job done. Because actually having a relationship that's authentic and open requires trust and vulnerability, and people may not feel that is safe for them. So cultural safety does not just apply to the people accessing a service, it's also about the work environment that people find themselves in, and whether they feel seen, heard, and respected as workers by the system they work for, by their colleagues and leaders. So we're at the point where we're going to chat. So we have about 15 minutes left. So I have a few slides with just questions that I have sort of put together. They're all quotes from other people. None of them are my brilliance. To get people thinking about how we could perhaps approach health and healthcare in a different way. So I will flip slides if people aren't offering comments and questions. But if people are really engaged, I will just let you go. So just a reminder, you have a comment or question, make sure you hit your mic so everyone can hear you, and know that you will be on camera when that happens. So fix your hair now and then hit your mic. So any questions or comments about this? I know this was a pretty lightning round version of this, like I said, very long, in-depth conversation. I have stunned you all into silence. It's my magic power in the world. So one of the things that I often think about in my work. Oh, hey, Regina.
Hi there. Thank you so much. I'm Dr. Parvez, pediatrician. One of the earlier slides where there was 8 years difference between the life expectancy between the privileged group and non-privileged one. I'm sorry if I'm using the wrong words. I'm looking at internationally, the most important thing which is skewed the whole life expectancy is infant mortality rate and child mortality rate. And that is one thing I'm very proud of Canada is pediatrics population as such between privileged and non-privileged there is a little bit discrepancy, but there's not huge discrepancy between mortality rates. If you compare this with third world countries, there is like 112 per thousand to 4 per thousand in one of the developed countries. So that is very much skewed because of the affordability and insurance, and I can give you a whole laundry list. I'm more interested is adult life, 18 and onwards. That's where the huge discrepancy is between privileged and non-privileged one. What is your comment on that?
Thank you for your comments and your questions. So I absolutely agree. Canada, health disparities in Canada look very different than they do in other parts of the world. And certainly there are lots of reasons for that. And there are particular subpopulations. I mean, 8-year life disparity, life expectancy at birth, is actually for like everybody. If we broke that out by subpopulations, that gap widens and narrows depending on different groups. But I think it's interesting to think about what we have done well in Canada and what perhaps we don't talk about as much or we haven't done very well at. And I think one of the things is particularly around Indigenous health in Canada, where we still have some pretty glaring disparities. But I think there's also been some strides in other parts of the world where we could be learning lessons, even if the disparities persist in other countries and other continents. How can we actually take those learnings and apply them here? And I think the other piece is, that was one example of a disparity. There certainly are more. And when we look at different periods of life, we see the disparities start to shift. And I think that was your question, was sort of about, you know, if we don't look at life expectancy at birth, we look at smaller segments of people's lives, we start to see the gaps change a little bit. And I think that information, while can be a little bit depressing to think about and overwhelming to imagine what we can do about, can be useful to actually inform our conversations, because we also tend, I think, to think we know what's going on, think we know where the gaps are, how broad they are, and so to have really meaningful conversations, we need to have really good data to actually guide our conversations and inform that. But we also need to be willing to talk about numbers in a way that demonstrates humility and vulnerability and openness to actually explore where we might be biased in looking at our data and even how it's collected and how it's analyzed and so on, which typically has not been because we perceive that process to be objective, which we know isn't necessarily always the case. If we look really deeply at how we do our work and how we view our data, we can be quite selective in what we hold up as evidence and what we dismiss. And some of that is for good reason. Some is because we've been conditioned to see some type of information or experience as not as important or not holding as much weight as others as well. So we've had some really interesting conversations. My unit tends to focus on epidemiology and other types of analysis of population level health information. And we've had some great conversations about where do human stories, lived experience fit in talking about what we're actually analyzing. Because we historically we've captured some story and we've engaged with community in terms of talking about what these numbers say. But even being able to say, perhaps this story is best told in words, in people's lived experience, and the numbers can take a back seat for a while, which typically it's been flipped the other way around. So the other thing I'm going to throw out there for folks is just the idea I mentioned earlier. In my experience in healthcare, I was asked, what's the matter? Oh, I should have had a clicker and kept count of how many times in my life, what's the matter? Usually sweetie or honey or something that made me cringe a little bit, or a lot. But what matters to you? And this has been something that I have found very interesting conversations with health providers, is we often have an idea of what is the best treatment approach, what is the most important information to give a family or an individual when they're being discharged from hospital or when they're being assessed at a geriatric clinic or whatever situation they're in. And we often aren't great at asking consistently, what is most important for you in this situation? So we may feel our information is just worth more important. And so it needs to be inserted in the conversation. And so it's important for us to be considering that, because it does have a relationship with how well people actually engage with us, whether they follow up with us, whether they can follow discharge instructions, all of these things. If we don't ask what matters to you, which could be something like finding a place to sleep tomorrow night. If we don't check that, we may have a whole other idea of what this person's social situation is and what their capacity is, what their interest is, even in following up with the referral we're going to make when they don't have an address to actually send the referral letter to. and so on. So we need to always ask what matters to you. It could be being alert enough to actually parent my kids. So if you're going to put me on a treatment that's going to compromise my sense of alertness, I am very unlikely to actually follow through with that, even though it may make the condition I've been diagnosed with better in some ways. So I think we're getting better at that for sure, but that's certainly a question. And I encourage people who are also in leadership positions or supervisory positions to ask this question of yourself, but also of the people that you're leading. So we often make decisions about what's the most important thing, whether that's at a huddle or a staff meeting or whatever. These are the important things you must know. And I think the opportunity to say, well, this is actually what I would like to know about, or this is the important thing for me to make sure we talk about, may not happen in every space. So I will leave you with some questions to think about or points to think about around integrating this into your work. Being able to just name it. If you're already doing some of this stuff, which I'm sure many of you are you actually framing it that way, naming that, and how your work is informed or related to health equity or cultural safety or cultural humility, because that starts to shift the understanding of those things, because people will be like, you said like cultural safety, I've never heard of that. What does that mean for you? Or tell me more about how you're doing that. Asking the right questions. So some of that is just what matters to you, who's not here, whose voice are we not hearing, those types of things. Identifying the metrics piece, which has been a fascinatingly challenging conversation around how do we actually measure our work in broader ways that tell us more about things like how culturally safe do people feel. Are we considering whether the things we measure are having us miss information, like whether we're widening gaps in health? Are we actually measuring somehow who is not showing up, who is not accessing our care, which I think is another fascinating conversation, because we often track who comes to appointments, and that's where our metrics come from. So are we looking at who could be here but isn't, who was referred to be here but doesn't come for whatever reason, who starts and stops? Sometimes that happens more, but which requires us to get creative with data and think about things a little bit differently. Are we engaging in our own learning and reflection? Is our team, is our system, is our community? And are we learning about and connecting, plugging into what's happening at a bigger level? So the former Saskatoon Health Authority or Health Region had Health Equity Position Statement. We are in the process of having that adopted for the Saskatchewan Health Authority. Most people in Saskatoon Health Region, when it existed, were like, I didn't know that was a thing. Partly because there were some challenges around communication, partly because people have enough to keep on track of every day. So it might require you to name this as a priority for the next year, for the next 5 years, to actually learn a little bit about what's going on. So I really believe health equity has often been seen as someone else's job in a certain department over there. Usually those people in public health do that, right? I believe it's everyone's job. We all can have an impact on this. We all can engage in this work. So I would ask you as you're leaving to reflect on what action you can take in whatever role you're in, whether you're a student, a preceptor, an instructor, a practitioner, a leader. What can you do to help achieve health equity in the health system? It may also be as a patient or family member in terms of how you navigate through the system and the questions you ask your providers, or the feedback you give us if you are given an opportunity to share that with us. I will try to find an avenue to get these slides to you guys, because there's a lot of links. The one thing that I encourage all of you to do is we have a monthly newsletter called Health Equity Cultural Safety Network News. It is literally just one email a month. I do not spam people. We share everything from learning opportunities, articles, practice guides, YouTube videos. It's basically all the stuff I get to see that a lot of other people don't have time or access to, and I try to condense it into, we theme it a little bit, share some stories of what's happening in the system, and try to get information out that way. So if you're interested in that, you can either chat with me, fire me an email, I'll get you signed up, or we'll get these slides to accessible somewhere on a website somewhere probably, so you can go track them down. But there's also some great resources that focus on different aspects of these topics. And as promised, my email address and phone number. So I'm expecting 1 million phone calls and emails after this, because you'll all want to talk more. But I appreciate the opportunity, and sorry we didn't have more time, but this is a series, so this is just the beginning. So hopefully this will be food for thought for the next in the series. And I thank very much the Dean's Office and the Division of Social Accountability. Okay. And all of you for taking time out of your very busy days to be here. And I would remind you to fill out the feedback sheets you were given as well. Is there anything else as people start to flee? No? We're good. Okay, thank you very much.